المحاضرة اليوم حتكون عن الانتراكانال medicaments and temporization. حنكمل فيها شوي على موضوع ثاني اللي هو الirrigation. بسم الله الرحمن الرحيم. تمام. الآن basic principles for the root canal treatment. شغل الكاميرا. Basic principle, the root canal treatment for successful endodontics to do a right diagnosis and then to do a biomechanical cleaning and shaping of the root canal. احنا بلشنا في الدياجنوسيس، اخذنا شوي عنها يمكن مع محاضرة oral medicine I think، واخذنا عن biomechanical cleaning and shaping، حكينا على step back، finally hermetically to seal the root canal system، نعمل good obturation. تمام. الآن in between حيكون عندي sometimes. تمام. شوي. In betweens could be إنه أنا عندي 2 visits or 1 visit. So in between visits what we will do, how we can خليني أحكي seal the root canal system until the second visit where we obturate. And what is the medication that we can place inside the root canal space that we create to prevent the regrowth of bacteria. This is the goal and this is the aim of this lecture. As we know, the goal of endodontic treatment is to destroy the microbial system and to disinfect the root canal system. However, we know that we cannot achieve that only by instrumentation or by irrigation. There will be still some bacteria resident inside the root canal space, even though that we did cleaning and shaping. In fact, cleaning and shaping in general, we only touch around 40% of the root canal space. And we don't touch the majority of the canal walls. Thus, this is an indication to place an intracanal medicaments to aid of the cleaning, the aid of decreasing the amount of bacteria. So the uses of intracanal medicaments to reduce inter-appointment pain, and this is questionable because it's actually will not reduce the inter-appointment pain. There's other studies that they considered the intracanal medicament will increase the inter-appointment pain, the incidence of inter-appointment pain. So this is what is written in the book. The aim of the intracanal medicaments to reduce the inter-appointment pain, decrease the bacterial count and prevent regrowth, and to render the root canal contents inert. Okay. What is the types of the intracanal medicaments that we use in our facility or all over the world? The first and the most famous one is the calcium hydroxide. And we have the calcium hydroxide. ممكن سكروا المايك إذا ممكن. Okay. The calcium hydroxide, we have it either in an aqueous form or in a dry form, powder. What other materials? It's like an historical materials. We don't use it anymore. Phenolics, aldehyde, steroids, antibiotics, and a combination of more than one thing. For example, antibiotic and steroids. It's a famous combination. Calcium hydroxide and antibiotics is a famous combination. We start with phenols and aldehyde. It has non-specific action and it can destroy both host tissue and the microbes. The use of the phenols and the aldehyde is based on opinions and it's empirical. It's not on evidence-based or on scientific base. Although you will find that there is still people using it. When we place it in the radicular space or in the bulb space, bulb chamber, the material will leak and it will go to the periradicular tissue. and thus it can cause some kind of systematic circulation, and it can go to the healthy tissue of the pulp. Also, do fixation of the tissue, okay? And it's more antigenic and toxic. It can cause formation of cancer. So it's advised not to use loose material, and it has no evidence of intra-appointment pain control. And the most famous phenol and aldehyde material we have is the farmcrazole, which we will find and see in majority of cases. We learned that the farmacrazole is the best material. When I was a student, they teach us that farmacrazole is the best material. The new evidence suggests that the farmacrazole is a toxic material, it is a carcinogenic material, and it should not be used. Another material is the iodine, potassium iodide. We don't have it in Jordan. It's common in UK. It has a good antibacterial properties as it has iodine. It has a low toxicity. It also has the ability to penetrate the dental tubules. The only problem with this material and the advantage is the tooth discoloration and also a possible allergic effect. Corticosteroids, we know the corticosteroids, cortisone, for example. It is an anti-inflammatory agent. It works on a higher level. It prevents the formation of arachidonic acid, and thus there will be no inflammation. It advocates for decreasing the post-operative pain. It is effective, but not in the high-level pain. And the most famous example is the leather mix. We don't have it. It's not registered in Jordan, but if you go outside, you would find the leather mix. It's a combination of tetracycline, an antibiotic, and corticosteroids. Okay. Now, we also have the chlorhexidine. Chlorhexidine can be used as intra-appointment dressing gel. It has a different concentration. It has 2% concentration, and it could be mixed with calcium hydroxide. It has a better clinical result found when mixing the chlorhexidine with the calcium hydroxide. However, it has a negative effect when it is mixed with sodium hypochlorite. You remember, we depend on the sodium hypochlorite for irrigation. So if we want to use the chlorhexidine as intracanal medicaments and to mix it with calcium hydroxide, it's important that we will clean the canal very well with normal saline. We should not have any residue of the sodium hypochlorite. Otherwise, if we have any residual amount of the sodium hypochlorite and we mix it to the chlorhexidine, we end up with something called brown precipitate, parachloroaniline. To give you an example, if you have a chlorhexidine mouthwash at home, try to mix it with a small amount of sodium hypochlorite, Clorox. So try to bring Clorox and chlorhexidine, the mouthwash, but small amount of both in one jar and mix them. You would have a material that is brown or orange in consistency, orange in color, and it has a granules in consistency. And this material is toxic, and normally it will block the dental tubules and it will prevent the killing of the bacteria. Okay. Now we come to the calcium hydroxide. It is the most popular material, and eventually in this era, only calcium hydroxide is used for intracanal medicaments. It could be medicated with other material. So the calcium hydroxide could be medicated with iodine, it could be medicated with chlorhexidine, could be medicated with antibiotic, anything, but the major amount will be the calcium hydroxide. So it is the most popular material. It has an alkaline pH, it's around 12 point something, and it inhibits the bacterial growth. It also helps in dissolving the necrotic tissue, but it has no pain effect, no pain reduction effect. It will not help in decreasing the pain. This is important. So the calcium hydroxide will not decrease the pain in between visits. For example, if you have one patient comes to you and this patient has severe pain and you inject the calcium hydroxide, the pain will increase, not decrease. So we have to consider other medication for pain control. It is also effective if it placed for around 7 days, a minimum of 7 days. So if we place it for 2 days, it has no effect. Also, it has a prolonged effect. So it can inhibit the microbes as long as it is used, okay, in the root canal. However, overusing this material, I mean by overusing, placing this material for more than 1 month could weaken the tooth structure. You remember the osmolarity pressure and the ion exchange between two media. So the calcium hydroxide has rich content of calcium, but with time this calcium will be depleted and it will start taking calcium from the dentine itself, and it will weaken the dentine. We have to notice as well that we have other combination or other material that is combined or made by adding it to calcium. For example, we have the iodine medicated calcium hydroxide, Metabix, for example, and we have something called Vitabix. The only difference between the Vitabix and the Metabix, Vitabix has something, has silicone inside. It has silicone addition beside the iodine and the calcium hydroxide, and it is difficult to be removed from the root canal system. However, it's considered a good material to perform bulbectomy in pediatric patients. So for pediatric patient, this material is considered an ideal as long as it will resolve, it will fill the space and it will resolve gradually. However, in endodontics, we don't use it because we cannot remove it from the root canal system. So remember, Vitabix we should not use. We can use anything else, but the Vitabix per se we should not use. Okay. How we place the calcium hydroxide? We have different forms of calcium hydroxide. We have the dry powder that we mix with glycerine or with, we can mix with the glycerine and we can mix it with water. We have the dry powder. We have the beef, the ready-made paste that is come in watery consistency. So the material could be inserted to the root canal using syringe, injection, or the lentil spiral, or the file. And the group that I supervise in the lab, you remember when we did the demo for calcium hydroxide, we insert the material by the file in anti-clockwise rotation. It's just the other way around. We don't rotate, we do rotate. Remember the hurricane, when we talk about the hurricane, how the movement of the hurricane clockwise manner that it will pull things up. It's the same. If we reverse that motion, we will insert the material in. So just you do de-rotation of the file, you will insert the material. Okay. How we remove it in between visits for preparation of obturation? We can remove it by irrigation or by file. And this material has a thixotropic property, which means like a kind of, not rubbery, but a kind of soft consistency. Okay. This is an example of placing calcium hydroxide by injection. So we insert the tip of the file 2 millimeters short of the working bend, and we inject the material. And while we inject the material, we go out. I will repeat the video. Okay. Sorry, let's go back. I will repeat this video first. So this is by injection. We insert the tip of the file down up to here, and then we inject. The problem with this technique that if we have resolved apex or large open apex, we cannot control the extrusion. So normally we have a stopper on the material itself. The other way is by using the file. So we insert a little amount on the file and we derotate. We rotate the file in anti-clockwise manner. Notice that? Okay, this is the anti-clockwise. Couple of times until the material extruded. So you can see that the material is filled in all the canal. We keep adding the material until we feel that it's enough and the material is finished. So what is the effect of the calcium hydroxide? It hydrolyzes the lipid motility of the bacteria lipopolysaccharides. So it hydrolyzes the lipid cover of the bacteria, especially the lipopolysaccharides. It dissolves the pulp tissue and enhances the effect of calcium sodium hypochlorite in between visits. Okay. We have also a medicated paper points with calcium hydroxide or getaberca, so we can insert those points, calcium hydroxide points in the canal and leave it inside. So this is the major techniques. We talk about calcium hydroxide insertion, the medicaments in general, and the calcium hydroxide. You will find more on the book if you would like. Okay. Now we move to temporization. In between visits, we need to temporize the case, and after finishing the operation, we need to keep the area hermetically sealed. So we need to temporize the space. So the function of the temporary restoration is to provide a coronal seal. And please remember this term, the coronal seal. It's important that we have coronal seal because this is one of the factors that would affect our success of the treatment. It can provide a coronal seal required for a few weeks sometimes, and sometimes it could extend to several months. It enhances isolation, as we will seal, for example, the box in class 2. And in this case, if we seal the box in class 2, there will be no leakage coming through the box to the tooth. And also, it could protect the tooth structure by spreading the occlusal forces on the tooth structure and not to have the occlusal forces on only a cusp, for example, a weak cusp. It also allows ease of placement and removal and should satisfy the aesthetics as possible. Okay. What types of temporary restoration? We have the famous type CAVIT, we have the intermediate restorative material RM, and we have the temporary endodontic restorative material term. Okay, the term we don't have it, actually it's not commonly used, but we have the CAVIT, the RM, and we have the glass animal. Okay, now CAVIT is the most famous, and it is zinc oxide base. It's not zinc oxide genol, remember that, it's zinc oxide base. It comes on a ready-made form. It is easy to be used. It sits in the presence of moisture. It has a good sealing properties. It has also a lower wear resistance, so it can withstand occlusive forces for a long period. Better to be used in short term because of the leakage. It has low wear resistance, so it will not withstand the occlusive forces for a longer period, and thus it should be used for a shorter period. And it comes in different color, pink, white, and gray. Normally, we can place it on 4 millimeter for around 3 weeks. Okay, and the clinical factor that we really care about is the thickness of the material. It should be at least 4 millimeter to provide seal. Okay. Now we have the RM, which is a zinc oxide egenol, and we have noticed that it has egenol based material. It's reinforced with polymethyl methacrylate, and thus it is strong. It can withstand the occlusal forces. It can withstand the occlusal forces, and normally it has enough occlusal forces that it can withstand. It will spread the occlusive forces on an even manner. It may be used for longer period. However, we have a problem with the eugenol, as it will prevent bonding in the future for composite. So one of the things that they advocate that we use a combination. Okay, we will come to the combination later on. Now we have something called term, which is special material designed for temporary restoration of the endodontic, and it has similar seal like the cavit. However, it has more strength, so it can withstand the occlusive forces. The problem with this material is it's quite expensive. Okay. Now, double seal. Why we mentioned the double seal? We talk about the cavit, that it will provide us with a good seal, but it has low wear resistance. It cannot withstand occlusive forces, and it will dissolve within a short period. However, the IRM, it has a good strength, but also it has a poor sealing ability. So another idea comes in people's mind that we should have something called combination. We can use a double seal. We can use one restorative material in the base and another restorative material that can withstand the wear on the top. For example, we can use glass ionomer on top of cavit, or IRM on top of cavit. Glass ionomer when a composite is plant placed, and IRM when amalgam, for example, plant placed. And on the base, we have 2 millimeters of cavit to provide seal. The method of placement, the cavity should be dry. So after we place calcium hydroxide, we place cotton roll to prevent the cavity from going inside. And the cotton roll should only cover the orifices of the canal. And then we start placing the temporary material exactly the same way we place composites on layers. So we should not use one shot because we will have spaces. We use layers after we place small amount of cotton. Okay. Right. This is an example of glass ionomer to be used as a temporary, but notice something. On the X-ray, we can see that it's not sealed on the margin. This is a common mistake when we place cotton on all the areas. So we have to be careful when we place cotton only to cover the orifices of the canal and not to cover the gingival margin, as if we place it like that, it will provide space for leakage and contamination of the canal. Okay. This is another example, you can see. And this is another example. So to do that, we have to be careful. After removing the caries, we have to be sure that the cotton is only covering the orifices of the canal. This is an example. So the cotton covering the orifices of the canal, and the glass ionomer is sealed, or the IRM is sealing the gingival margin. Okay. Finally, we have to place a permanent restoration, and while placing permanent restoration, we have to remove 1 to 2 millimeters of the guttapercha below the orifices, below the cemento-enamel junction. And this technique, we call it layer technique. So we remove by Getzegliden 1 to 2 millimeters of the guttapercha, and we condense our material on top of the guttapercha. If we use composite, it's better to place glass ionomer on top of guttapercha to prevent the zinc oxide eugenol and the guttapercha of preventing the composite from setting. Okay. Other option for permanent restoration, we can use Boston core. if we have like a lost tooth structure and a crown in certain cases where also we don't have enough tooth structure. Okay. Now, before moving to the last part, I'm talking about the irrigant. This is a part of the cleaning and shaping lecture that we did not finish. So we'll talk about the major irrigants that we use in our endodontic office. The properties of an ideal irrigant: to have an organic tissue solvent, to be inorganic tissue solvent, to has an antibacterial action, to be non-toxic, to have a low surface tension, and to lubricate the canals. Now, if you notice, to have organic and inorganic tissue solvent, it's quite difficult together. It's either very strong material or it could work selectively on one of the tissue. Also, to have an antibacterial action without being toxic to the normal tissue is quite difficult as well. The low surface tension, we need it so the material can go inside and spread, covering everything, and to lubricate actually the files. Now, the best material that we have, and this is the only thing that we agree totally on endodontics, is using sodium hypochlorite. Okay, the concentration is quite different, but choosing sodium hypochlorite is the one we agreed that this is a material we can use as an organic solvent. It kills bacteria and it can spread easily inside the root canal. Other material we use like EDTA, and it was a time that they considered chlorhexidine as a part of the irrigation protocol. So this is the major three materials we can use in endo for irrigation. Sodium hypochlorite is the most common irrigant. It is the same household bleach. The advantages of the sodium hypochlorite: it has a mechanical flushing of the debris from the canal because of the volume. We use a volume of sodium hypochlorite. It has the ability to dissolve the vital and necrotic tissues. So because of this ability of dissolving the tissue, it will enhance the cleaning of the canal. It has an antimicrobial effect, as well as it has an anti-tissue effect. So it could affect both normal tissues and disease tissue or bacteria. It will also help to lubricate the canal, and it is inexpensive and available. How it works: the free chlorine in the sodium hypochlorite dissolve necrotic tissue by breaking down the proteins into amino acids. Now, regarding the concentration, there is no difference actually in the antibacterial effect between the 0.05 up to full concentration 5.5. However, the full concentration, it has a better ability to dissolve tissue. So as an antibacterial effect, low concentration is equal to high concentration, but as a dissolving effect, the higher concentration is better, and heating the sodium will increase the efficiency of dissolving the tissue. So as a recommendation, we can use the 2.5, which is like 50% diluted sodium hypochlorite. So we mix normal saline to sodium hypochlorite in equal amounts. Now, at this age of coronavirus, one of the things that we can use for inside the house for disinfect the tissues is by diluting sodium hypochlorite 10 times. So we have the 0.05% sodium hypochlorite, and we can use it to disinfect anywhere, bathrooms or kitchen or even different surfaces. So sodium hypochlorite is the universal material for disinfecting. Now, decreasing the concentration can be compensated by increasing the volume. So if we decrease the concentration, we remember, if we decrease the concentration, it will affect the dissolving effect. So we can increase the volume. We can irrigate in larger amount to dissolve the tissue. Warming the solution could also increase the effect. The irrigation needle should be used loosely inside the root canal. to prevent sodium chloride accident. You have to remember that the needle should not stuck inside the root canal. Otherwise, if the needle stuck with pressure, the material will go outside the apex and it will cause damage to the tissue, to the normal tissue, and will end up with something called sodium chloride accident, which is a devastating situation where the pain will be increasing very much and the patient will have swelling, and sometimes we need to admit to the hospital. Also, the irrigant normally will not move beyond the needle more than 1 millimeter. So the length where the needle should stop is important. We have to measure how much we go inside the root canal, and usually we should go up to the apical nerve. Okay. Now, EDTA is another material we can use for other purpose. EDTA is the ethyl diamine tetraacetic acid, and it has the concentration of 17%, and it has an effect on the inorganic tissue. It will help to remove the smear layer. And you remember, while cleaning and shaving, we have like small debris, the smear layer that will occlude the dentinal tubules. By removing the smear layer, we will enhance the action of sodium. And also, EDTA has an effect on the bacteria biofilm by decreasing the